Hello, Ravens. Dr. Richardson here to talk about pressure injuries. Let's go. Okay, so this is lecture 2 from Foundations 2, and just a couple of quick comments because all of this is interrelated. Uh, our first lecture dealt with positioning and draping, and so we talked a lot about the importance for patients in this inpatient type scenario who are less mobile and a little sicker, and the importance of avoiding damage to skin and joints. And at the end of the first lecture, we talked about footboards in beds, and I was kind of hurrying because my recording tool has a 15-minute limit on it, and so I finished that first lecture up right at 15 minutes, and this one we'll probably do a part 1 and part 2. When patients are in hospital beds, very often they gravitate towards the foot of the bed. Often the head of the bed is lifted or elevated, and as patients move around, they gradually start sliding towards the foot of the bed, and therefore footboards can be valuable because they stop that movement towards the foot of the bed, and they keep the ankle in a neutral dorsiflexion, plantar flexion position. We've talked before about contractures, and very often for patients who are in bed, a lot of the time the bed sheets will keep the ankles in a plantar flex position, and often that results in a plantar flexion contracture, and they are not able to achieve full dorsiflexion. So just a couple of uh, comments about the end of that first lecture there, kind of the reason for footboards. We also talked about draw sheets, and same idea. As patients gravitate towards the foot of the bed, the draw sheets are a useful tool to lift the patient and move them towards the head of the bed. Okay, so we talked about the pressure points for patients in various positions, supine, sideline, prone, in the first lecture, and we'll talk a little bit more about that today as we discuss pressure injuries. These pressure injuries were previously called pressure ulcers or decubitus ulcers, and recently that terminology has been changed to use pressure injuries as the uh, preferred nomenclature. So our objectives for this lecture are to talk about the negative deleterious effects of bed rest. We're going to talk about staging a pressure injury and how that is documented as well. Also, individuals at risk and why they're at risk for pressure injuries, and the frequency that patients need to be changing positions to avoid these pressure injuries. So, as you can imagine, a patient, for whatever reason it is spending lots of time and all their time in bed, and they're not changing positions much, they're not ambulating. These are all quite obvious. They're going to lose muscle strength, they're going to be more fatigued, lose activity tolerance, lose endurance, and then specifically from a cardiac standpoint, decreased stroke volume and decreased basically cardiac output and their ability to uh, oxygen uptake, and therefore they're not getting as the heart's not as efficient, and therefore they're not getting as much oxygen to the tissues. All of these factors combine to result in decreased muscle mass and decreased bone density. So when you think about that, all those issues that were discussed on the previous slide, why do you think that happens? So why do people lose muscle strength, have increased fatigue, decreased cardiac function, and muscle mass and bone density? Why is that happening? So those are some things for you to think about and consider. Uh, and I think they're all quite self-explanatory, but important for you to consider. I know you're also taking pathophysiology this term from Dr. Rohde, and so there will be discussion about those various body functions. So, some additional effects of bed rest that are negative effects: the risk for a blood clot or a DVT, a deep vein thrombosis, also orthostatic hypotension, and of course, pressure injuries. So, a DVT, a deep vein thrombosis, these can be fatal, can be very dangerous, and so as physical therapists, we need to be aware of the potentiality of a blood clot. Most commonly in the lower leg, they can happen in many different areas. Wherever there's a vein, blood can clot in that vein. So we want to look at some of the key identifying factors, and one of those is that the symptoms are unilateral. When you have a patient with bilateral swelling in the lower legs, decreased circulation in the lower legs, then we think more systemically. We think, okay, it's a cardiac output type of issue, because in general, the entire cardiac system is not functioning appropriately or efficiently, and therefore blood is not getting, there's not sufficient pressure to remove the fluid from the lower extremities, and so we have bilateral swelling. When we have unilateral swelling, then we start thinking that it could be some sort of a blood clot or a DVT. So these are the things we look for: swelling in the lower extremity, and as measured by increase of leg girth, difference side to side, and you see the difference between males and females. If the lower extremity is warm, tender, painful, if there's discoloration, and if there's we can literally palpate and feel a hardened area in the lower leg. And there's a clinical prediction rule that we can utilize known as Wells criteria. So this clinical prediction tool gives us the ability to look at these various factors and help us predict whether or not DVT is likely. So let's jump ahead one slide real quickly and look at a score of 2 or more that a DVT is likely, less than 2, unlikely. And so then, of course, the higher score we get above 2, the likelihood increases quite significantly. And if someone has these kinds of symptoms that we're applying Wells criteria in both legs, we're going to look at the leg that has the higher score. So let's go back now to these different criteria. So active cancer gets a point. Paralysis or weakness or a body part being immobilized in a cast, I'll get a point. If someone's been in bed for more than 3 days or had a major surgery in the last 2 weeks with general or regional anesthesia, that gets a point. If they have that local tenderness along, and we talk about the distribution of the deep venous system, here's Dr. Kraut's anatomy coming in to help you out here. We kind of know where those major veins are in the lower extremities. If we have tenderness right there, that's a point. If the entire leg is swollen, that's a point. And then specifically in the lower leg, if the calf is greater than 3 centimeters larger than the other side, that's a point. Pitting edema, which is edema where you, with the end of your index finger, push into an area with edema, and the edema stays, and it takes significant time for the leg to return to normal. That's pitting edema. That would be a point. If they have superficial veins that are symptomatic, that can be a point. If they've had a DVT previously, that can be a point. And so all of these can add up to give us the ability to then look at these various factors and say, okay, it looks to me, and the very last bullet point here is there's something else that could be also causing these symptoms, then that may take some of the points away. But in general, this is a quick and dirty way for us to assess a patient and say, oh my goodness, they've recently had surgery, they have tenderness in the leg and or swelling in the leg. Like, those are the most common applications of this criteria, and we're going to say they are at risk for a DVT. Okay, so then we go to the next negative factor of bed rest, which is orthostatic hypotension. So this is a decrease in systolic blood pressure. It's kind of defined by at least 20 millimeters of mercury, or a diastolic decrease of at least 10 millimeters of mercury within the first 3 minutes of a position change. So typically this is your bedridden patient who you move from supine to sitting or from sitting to standing, but that major body position change and the body is not able to accommodate the change in the blood flow pooling in the lower extremities, for example. And so that is why orthostatic hypotension happens. It's not a disease, it's basically the body system not responding effectively to a position change. Um, it can be something that's merely related with aging. It can be a side effect of medications. If a patient has congestive heart failure or is pregnant, that can also be a reason that the system would not respond quickly enough when you have a major body position change. There may be neurological reasons for this. If someone's been on anesthesia or on bed rest, all of these things can cause this to happen. And so, in essence, we as physical therapists, we're trying to get our patients up, move them, have them be active. And so, obviously, as we do this, if a patient is suddenly dizzy, they're ready to black out, their vision is changing, or their cognition is changing, or they feel weak. So these are all symptoms, and so therefore the need for us to be maintaining eye contact with our patient, often maintaining a dialogue with them as we're going through our session. So we're talking to them. Let's say our patient is lying supine in bed. We come in, we introduce ourselves. We're going to do our physical therapy evaluation or session today, and they're able to maintain a dialogue with us. And so as we then move from supine to sitting on the edge of the bed, if suddenly they are unable to maintain the conversation, or they are stating to us that they are dizzy, or they can't see well, or they feel very weak, then we are immediately thinking of the potential for orthostatic hypotension. So in some cases, we might predict that this will happen. And so one way to do that is to take a blood pressure in supine, take it again once they've moved to a sitting position, take it again once they're standing. And so all of those can be ways to monitor that. Most typically, it's just the patient's reported symptoms. They sit up on the edge of the bed. Oh my goodness, I feel so dizzy right now. And so sometimes, depending on the severity of the symptoms, we may say, okay, we're going to stay in this seated position on the edge of the bed, and let's keep talking. You tell me if it's getting better. Very often, after 15, 30 seconds, the symptoms resolve. And so great. So let's try to stand up. Maybe they stand up and they start to feel it again. Of course, we're guarding the patient very carefully. We keep talking to them, and sometimes the symptoms resolve, and we can the body has now compensated, and we can continue with our mobility activities, such as, okay, now we're going to transfer to your wheelchair, or we're going to go for a walk. In other situations, we move the patient from supine to sitting. They become very dizzy. We're talking to them, and the symptoms worsen, or they do not resolve, and so we lie the patient back down and wait for the symptoms to resolve. And we just need to monitor the situation closely. We'll talk about this quite a bit more as the term develops. But in general, we give the patient system a chance to resolve. If it doesn't, then we'll move back to sitting if they were standing, or supine if they were sitting, let the symptoms resolve, and try again. And so often it is merely if a patient's been on bed rest for quite a while and they are struggling with these position changes, we just need to give their system the chance to adapt. And so a lot of times we move supine to sit. Okay, this time we lasted 45 seconds, and before we had to lie back down, we rest till the symptoms resolve. We sit back up again. Okay, this time we lasted 2 minutes. And other people just they resolve very quickly, and we can move on. But that is orthostatic hypotension. This will end part 1. We'll come back with part 2.